Okay, our next case is a patient who comes in with paroxysmal colicky pain and blood in the stool. You have a 2-year-old toddler who's brought to the office by his extremely concerned mother because he just passed a stool with red blood and mucus. He's been irritable for the last 36 hours. He's had intermittent attacks of belly pain accompanied by straining efforts and loud cries. So as soon as you read that sentence, you need to be thinking that this person is having intermittent colicky pain. It's coming and it's going. It's acute, okay? It's not been a chronic problem. It's just occurred in the last day or so. And so you need to be thinking, is some active process going on here that needs to be taken care of immediately? He also has had a few episodes of emesis, but none in the last 24 hours. A week ago, he had mild diarrhea and an upper respiratory infection that has resolved spontaneously over the last 5 days. He has no other known medical problems, and he's growing and developing well. Physical exam shows you a pale, very irritable child with a fever, a pulse of 120, and a blood pressure of 90/60. You need to ask yourself, is this pulse good for this age group? And the answer is yes. Remember that at birth, your heart rate is usually 140 to 160. When you get to be a toddler, it goes to about 120. When you get to be school age, first, second grade, it's about 100. And then when you get to be an adolescent, it's going to be like an adult, about 80. So this is okay. His physical exam further shows that he has a normal HENT exam, but he has a pale skin with no rash. His heart rate is normal, and he has clear lungs. When we get to the abdominal exam, we note that his abdomen is distended on deep palpation. And when you go to examine the patient, you find that the patient has a right upper abdominal mass that seems to be sausage-shaped. This is the clue. This is the key to the whole case. Once you see the word sausage-shaped mass, you should be immediately thinking that this patient has an intussusception. All right? So sausage-shaped is your buzzword. It goes with intussusception. They may say to you that you have a right lower quadrant emptiness. Why? Because you have this sausage-shaped mass that has risen up. If they say to you that the patient has dances, D-A-N-C-E-S sign, that just means that the right lower quadrant appears to be empty. So they could do it either way, sausage-shaped mass or dances sign. What other things do you need to be noting here? Basically that there's no hepatosplenomegaly. Has good capillary refill, and neurologically, it's grossly intact. So you need to formulate a differential diagnosis. The first one would be intussusception. The sausage-shaped mass pretty much sums it all up. However, other things that you could be thinking about would be a Meckel's diverticulum that's bleeding, or Henoch-Schönlein purpura is associated with intussusception and may present with abdominal pain. So those three things should be in your differential diagnosis. So how would I manage this? What would I get to help me? Well, the first thing that we would want to get would be a complete blood count. We're looking to see what the white cells are, if there's any evidence of infection. The white count is 14,000, and it has 85% neutrophils. And there are some bands. He has a hemoglobin of 10. That's odd. He's anemic. So maybe he has some bleeding, or maybe he has iron deficiency anemia. You do an abdominal radiograph, and you find that he has a density that can be seen in the right upper quadrant. You note that his abdomen is distended, and intussusception is really your working diagnosis. The patient who has intussusception actually has an involuted piece of bowel. So what does that mean? That means that if this was the intestine, that actually it's folding in on itself. It's folding backwards. So this is going inside out. It would be like putting your hand through your sock and pulling it through. That's not good. Why? Because the patient can get a necrotic bowel. Why? Because the patient can go into shock. Why? Because children have died from intussusception. So this is an acute emergency. So you want to try to avoid that. The clue, the history, the sausage-shaped mass, the Dance's sign, the intermittent colicky pain. They may say that the patient is intermittently pulling the legs up and then intermittently looking fine, letting it go. Because you can even have an intermittent intussusception where the bowel is going in and out on itself. All right, so this is a person that you want to get intravenous fluid started on. You want to start the hydration. This is also a person that is known to sometimes having bloody stools. Okay? You might have heard the word current jelly stools associated with intussusception. If you have current jelly stools, that means the intestine is sloughing. All right? That is a bad sign. You want to try to make your diagnosis prior to current jelly stools. So they may not give you the current jelly sign because they think everybody knows intussusception goes with current jelly stools. So they might just give you these other hints on physical examination. All right? What else do we need to be thinking about? If I had a Meckel's, my bleeding is usually painless. All right? And usually sometimes it can be brick red would be the buzzword that they would use as far as describing the stool. Sometimes they might make it a little difficult for you because sometimes the person who has a Meckel's can also be described as having a current jelly stool. But to be more fair, they would say brick red stool or bowel movement. He's bleeding. The other thing that you'd be thinking about for the Henoch-Schönlein purpura would be that these children usually have an intussusception that's higher up. All right? These children might present with hematuria because Henoch-Schönlein is a vasculitis and it can affect the kidney in addition to affecting the abdomen and causing an intussusception. So you need to be thinking about that. However, because you've pulled out the sausage-shaped mass and you know that that working diagnosis should be intussusception, you're going to order a barium enema. Why are you ordering a barium enema? If you could only do one thing, that's it, and immediately. Why? Because the barium enema is both therapeutic and diagnostic. Okay? So if you have the intussusception where the intestine is involuted on itself, if I give a barium, I'm going to try to push the rest of that bowel out. All right? However, what could happen? We could have perforation. What other things could happen? It may not work. If it doesn't work, or as it's working, what will you see on X-ray? They might give you the key word, a coiled spring sign is seen on X-ray or on radiograph. Looks like a slinky. That would go with intussusception. If you cannot reduce it therapeutically with the barium enema, then what you would have to do is go to surgery. All right. And on your result, you found intussusception. Now, going through our case reviews, let's think about intussusception. I think that we've talked enough to say that it's an colicky abdominal pain, that there's a sausage-shaped mass, and barium enema is diagnostic and therapeutic. How do I know that this person who may or may not develop current jelly stool or red stool doesn't have gastroenteritis. Well, think about it. Those kids could have vomiting. They might be around ill contacts. They might say that they go to daycare. Usually, though, the stool doesn't have gross blood. And the pain is usually more diffuse, less regular. The children usually don't bring their legs up and then let them down. All right? So they just kind of have the pain without really actively showing or demonstrating it. What about Meckel's diverticulum? Painless rectal bleeding. All right? You may have a patient who comes to your office, this could be on your exam, that the patient has anemia. And you know in children, when children have anemia, usually our workup is limited. We usually would just get a reticulocyte count and start the patient on iron. However, if they made a case for a Meckel's diverticulum, what they would say to you is that this patient is not responding to iron. All right? So if he's not responding to iron, he might have thalassemia, but the other thing you need to be thinking about is, does he have painless rectal bleed because he has a Meckel's? Now, remember that for Meckel's diverticulum, that basically you're going to have a remnant portion of the embryonic yolk sac that is still present. And instead of involuting during gestational age, it stays. And basically, it's the rule of twos. It's usually 2 inches long, 2 feet from the ileocecal valve. 2% of our population have it. And it commonly presents in 2 years of life. Now, it's important to note that you can still diagnose a Meckel's diverticulum after the age of 2. But this is just one way to remember, generally, who's getting it and how it's located and when it presents. Now, if you wanted to do the next step for a Meckel's diverticulum, it would be a Meckel's scan. However, the examiners are not that kind to you, so they're not going to put Meckel's scan down. What they're going to put down is that one of the tests of choice might be a 99 M per technetate test. And basically what I'm going to do is spell that for you. It'll be PERTECHNETATE, or they might say technetium 99M. All right? So anytime you see the technetium 99M with the painless rectal bleed and you're suspicious of Meckel's, anemia that is not responding to the iron. Remember that a Meckel's could be your lead point for intussusception. All right? Because it would be involuting on itself. Okay? It would cause the intestine to involute on itself. What about Henoch-Schönlein purpura? Well, usually those children have a characteristic rash. They usually have joint symptoms, pain, arthritis. They might have central nervous system involvement or renal involvement. We talked about the hematuria. And again, Henoch-Schönlein purpura has an association with intussusception. And so for the Henoch-Schönlein purpura, we said that the intussusception is higher. Therefore, a barium enema won't always be helpful to you. So what could you do? The examiners, or in real life, as the physician for these children, you need to know that your first step is a little different in children with Henoch-Schönlein purpura who have a suspected intussusception. You would need to give those children steroid. And the reason you give the steroid is if this is a vasculitis and that's your lead, causing your lead point in the intestine, you're trying to get rid of the inflammatory response by using the steroid. All right, our next case is going to be a case of a 7-year-old who has short stature. Let's look at our history. We have a 7-year-old male who's brought to the office because of parental concern about his growth. His mother has had an uneventful pregnancy, and delivery was via normal spontaneous vaginal delivery. Both the mother and the newborn left the hospital within 2 days, and the child was breastfed for the first 6 months. He sat up at 7 months of age and walked with assistance at 11 months. So far, this is a completely normal child. All of his developmental milestones were within normal limits. However, he was found on the growth chart to be at the 5th percentile during early childhood and remained there until this time. There was no prior history of any systemic illness, and he has a good appetite, being at the 30th percentile for weight. So you need to make a note of that. He's normal weight, but he's short. Okay? There are 2 other siblings, a brother age 2 in good health and at the 15th percentile for height. His sister age 12 is also in good health. His father is 6 feet tall, and his mother is 5 feet 5 inches. So it doesn't seem that genetically he comes from excessively short family. So you start to question the father. And the father states that he was usually shorter than his friends in school until the age of about 14. There's no history of headache and no vomiting. There's no visual disturbance, no anorexia, no diarrhea. There's also no history of polyuria or polydipsia. Here you would be thinking that the patient might have a diabetes insipidus. The patient appears to be in no acute distress. He's very friendly and cooperative. His short stature is the only obvious abnormality. So we go to the physical examination. And really, on physical examination, we note that the HENT exam is within normal limits. He does have some mild tonsillar hypertrophy bilaterally, but he has no shift of his uvula. His neck is supple. There's no thyroid masses. Trachea seems to be in midline. His lungs show no evidence of pathology, nor does his heart. His abdomen shows positive bowel sounds. It's non-tender. There's no organomegaly appreciated. And really not much truncal fat disposition, thinking about an endocrine problem. Genitalia. He's Tanner 1. His testicles are descended bilaterally, and there's no inguinal adenopathy. Remember that Tanner stage 1 is normal for 7 years. This is immature genitalia, and that would be normal. He has full range of motion of all his extremities, good tone, good pulses, and neurologically, he has no focal deficits. So when you're thinking about this particular case, the reason the parents came to you is that the parents are concerned that their child is short. And you know that in pediatrics, or as a generalist, if you were seeing children, that you would be responsible to follow the growth of those children. And usually at our well-child visits, up to the age of 3 years, we get measurements on the head, we measure the height, and we measure the weight. And the reason we do this is to see if the patient is progressing within, in quote, normal limits. Why would we measure the head? We want to make sure that the brain is growing, all right? That the head is not too small, or that the patient is not developing hydrocephalus. Why do we measure the weight? We want to see if the diet is adequate, if the patient is failing to thrive. Does the patient have some organic illness that's keeping him or her from gaining weight? Was there something in their life that happened at a moment in time where they were doing beautifully and suddenly they developed renal disease and now they're falling off the growth chart for weight? What you know from your studies is that the weight is usually the first to go. The height goes second, and the third thing to go would be your head. So if you had a symmetrical problem, that would be a worse indicator. That means that something happened that affected all three. We have a problem in this case. The problem is that the patient is in the 30th percent for weight, which is pretty well within normal limits, and that the height is only at the 5th percentile. So that's opposite of what we would have anticipated. Now, the next thing that I'd just like to make a point, since we're on this height and weight, remember that an infant will double their birth weight by about 4 to 5 months, or between 4 to 6 months of age. A patient will triple their birth weight by about 1 year. Now, the other thing that you need to remember is for the height, that the patient will be half of their adult height, usually by the age of 2. So you're half your adult height, usually by the age of 2. That's a good rule of thumb. All right. Now, getting back to this particular case, what could be our differential diagnosis? Why could this child be short? Well, first of all, you just can't, as a general medical doctor or a pediatrician on the first time seeing a 7-year-old, use one growth point and know what your diagnosis is. You need to see what the trend is. You need to look to see, is this patient between the 5th percentile and the 95th percentile? If the patient is above that, either for weight, height, or head circumference, then that means that the patient is more than the norm. If the patient is on or below the 5th percentile, and I would say if the patient is below the 5th percentile, then that person is less than the norm. 5 percentile is not bad. That's within the norm. But in this case, the parents want to know why. Is it genetic? Did the patient acquire something that's causing them to be short? Well, from the history, it sounds like he's always been short. But what if the patient had been on the 50th percentile for height and now is down at the 10 or the 5th percentile? That means the patient's failing. Something happened in that patient's life to make the patient drop off the curve. Because from your studies, you know that after the age of 2, you can never cross tracks on your growth curves. So if you, by age 2, are in the 50th percentile, you should not go down now to the 25th percentile one visit, 75th percentile for another visit. You should continue along the same track. You also know from your studies that if you have a premature patient, that these patients should be plotted on these growth curves by where they would have been in their chronological age from their gestational age. What do I mean by that? If they were 4 weeks premature, then when you start to plot, you need to plot them always 1 month behind. All right? If they were 3 months behind, you plot them 3 months behind. So if I had, for instance, a person who was 1 year old but premature by 3 months, I would plot them on the 9-month curve. And the reason I do that is to give them an opportunity to catch up. But they should have caught up by 2 years of age. After 2 years, it doesn't matter if you were premature or not, you need to make sure that you're plotted at chronological age. The other thing that you need to know is that certain groups in our population, such as those with trisomy 21 or Down syndrome, have their own special curves. So you wouldn't use a Down syndrome curve, plot a Down syndrome patient on the same curve as the general population because they tend to be short and stocky. Now, getting back to our case, what's the bottom line here? What do we really need to be thinking about? Does the patient have, since this patient has consistently been going along the 5th percentile, is this patient short because he's genetically short? Or is this patient short because he has something called constitutional delay? All right? Now, if you had an opportunity to do a complete workup. You could do a CBC, electrolytes, a SED rate, a urinalysis, a third-generation thyroid-stimulating hormone, an X-ray of the left hand and wrist, and a growth factor concentration. On your exam, you have 1 minute to figure this out. If you wanted to choose the best test that would give you the diagnosis, it would be an X-ray of the left hand and wrist, and move on. All right? So you might say, well, how is that going to help us? Well, first of all, let's just look at our results. Your WBC count was 8,200, which was within normal limits, as was your hemoglobin and hematocrit. Your calcium and phosphorus were all within the normal limits. Your electrolytes were within normal limits. Your SED rate was 15, and everything else that you were testing appeared to be within normal limits, except if you looked at the bone age for this particular patient, you would see that there was a delay in bone age. So what does that mean? Okay, I have a 7-year-old boy that comes to the office, and you want to know the best way to decide, is he short for genetics or does he have this thing called constitutional delay? And I always tell a story about a young boy that I went to high school with, because I oftentimes get emails from my students at Kaplan who say, I saw your friend on my test and I picked the right answer. And I think it will be clearer. When I was in high school in 9th grade, I took Spanish, and I always sat next to a boy named Bill. And basically, every day, Bill would come to class, and for some reason, he was really short. And he would just always say to me, hi, I'm short. But I'm not always going to be short. My dad is 6'2". He was short. And I used to think, my gosh, why does he tell me this every day in the 9th grade? But then I went to the 10th grade, and he told me the same thing, and he wasn't making too much progress. Let me just say this. And so he'd go on and on and on about his dad being tall, and he wasn't always going to be short. Sure enough, it was high school graduation. And I'll tell you that he probably made progress just for about maybe 2 to 3 inches. He maybe just hit the 5'3". Okay? But he was short, and it's okay to be short. But he kept bringing it onto himself. Okay? I thought, I was always wondered why I keep bringing up something that, maybe he didn't like it. Sure enough, we graduated. I kind of felt bad for him, because I thought, well, he's always saying this, but we're already graduated. He should be finished growing by now. All right? So the years went by, and I went to medical school, and I took the same tests that you took, constitutional delay, short stature. Every time I saw one of these growth things, I just think, oh, I don't really understand it. Maybe that's a point I should just give up. Don't give it up, because I can teach you how to read these growth charts. And, they're always going to put at least 5 of these things in your test. And so I come back for a high school reunion in 10 years, and by then I'm a doctor, I'm in medical school. And sure enough, I'm from a small town, and so I know who married whom, because it was such a small class. So I said to my best friend, who is that man standing next to the pole? Who did he marry? Because I didn't recognize him. It was only 10 years, and I should have known everybody in my class. My friend says to me, you're never going to believe it. She's 5'10". She was always the tallest girl in our class. She said, remember that boy that sat next to us in Spanish and kept telling us about how he was going to be tall? She said, this man standing next to the pole was like 6'3". She said, there he is. And so, sure enough, it was then that I realized that this was constitutional delay. So what does that mean? If he or this young man in our exam had a wrist X-ray, like our young man in this particular case, the growth plates would not be consistent with chronological age. So the radiologists in this group, you know that you have a special book of left-hand pictures of people who are 1 and 2 and 3 and 4 and 5. And if I take the picture and my bone age of my left-hand wrist is the age of a 4-year-old and I'm 7, really in true life, then that means I have plenty of room to catch up. However, if I'm 7 years old and my bone age is 7, then I'm where I'm supposed to be. And that means I'm just short. So that's how you would attest the constitutional delay versus the familial short stature. And it doesn't have to be a big deal, and they probably will put lots of labs on, the growth hormone, and a whole ton of CBCs, and you're going to be wondering, my gosh, all this information. But if you just go to the wrist and see what that shows, that makes your diagnosis. All right. Now, I think we pretty much talked about the assessment. If we wanted to do any other diagnostic plan, as I said, you can't make a decision just with one point. So you should always review old records or have the patient's family send you the old medical records so you can see where the other plots were plotted. Okay, the other points were plotted. Okay, because just to have one piece of information doesn't help because there are many things that go into a growth chart. All right, and when you did look at the old records, though, you saw that this particular patient on your exam or in your case history here had a normal growth velocity. So he was always the 5th percentile. So there was no disease like a brain tumor or diabetes insipidus that caused him to fail. This is just him. So it only can be the short stature or the patient who has the constitutional delay. And that will bring us to our next case. Could we just, before we go to our next case, do you have a chart in there about your differential diagnosis? Okay, could we just go over that? Okay. All right. The last comment that I would like to make regarding the therapy and the differential diagnosis of short stature is to look at our chart and just to point out to you the highlights of how you can remember what information goes with what so that you can quickly make an assessment on your examination. We've talked about the constitutional delay and the familial short stature. There is another person that could be short, and that would be the person who has deprivational dwarfism, the young lady who has Turner syndrome, and a person who has hypothyroidism. And if you looked at your chart, remember that the sex would be able to help you for somebody who's short because the Turner syndrome is always female, and in constitutional delay, males are usually greater than females. So there are more males who have constitutional delay than females. What's important about the facies? Well, everybody's facies is normal, except if you look at your chart, the Turner syndrome may have some Turner's facies or a webbed neck, all right? And the person who has hypothyroidism would have that cretin look. What does that mean? That means that the baby may have large fontanelles, that the patient may be chubby in appearance, the patient may be passive, the patient may have a protruding tongue, all right? So the patient may have an umbilical hernia. So those things would make you lead towards the fact that this person is short because they have hypothyroidism or cretin. They're a cretin. The other things that if you looked if you thought about the bone age, we talked that for familial short stature, the bone age is normal. In everybody else, it's delayed. What else? The chromosomes. The main buzz that you would need to know there is that for Turner syndrome, it's XO. Otherwise, phenotypically, everybody else should be normal. If we looked at tests that we could do, if you suspected Turner syndrome, you need to make sure that you would think that to do a karyotype. All right? If you suspect hypothyroidism, you need a thyroid panel. And if you suspect that a person is short or small because of deprivation, what does that mean? Emotional nurturing or physical nurturing to bring that patient to their highest potential, then the idea would be to put that person into a controlled environment so that you can observe them. And then the last thing that we want to talk about is therapy. And in order to determine what your management would be, you have to make your diagnosis. Okay? For instance, if you had a patient who had hypothyroidism, then you want to replace the hormone. If you had a patient who had constitutional delay, like my friend who had so much confidence, you'd need reassurance. All right? If you had deprivational dwarfism, you would improve the environment. So I think that if you approach our grid in that way, with what's different or what's exceptional, that would help you to pull it out when you're going through your different scenarios on your examination or in your daily practice when you're treating patients. All right. The next case that we're going to do is a 15-month-old with ongoing growth failure, fluctuating episodes of coughing during feeding, and associated vomiting. Okay. You have a 15-month-old girl who's brought to the physician because of a cough with feeding that has not improved over the last few months. There was initial spitting up of formula, which seemed to be partially relieved by adding cereal to the formula. Okay, so this sounds like what we spoke about before, gastroesophageal reflux, right? They added the cereal, seemed to be better. She was just spitting up with a burp. The mother states that the infant always required a longer time for feeding, for which she was told that the infant would eventually outgrow. However, the symptoms have been intermittent, and there is sometimes associated coughing. There was one episode of pneumonia in the right lung, which required hospitalization. The baby, however, responded well to intravenous antibiotics. Now think about it. You have a patient that's spitting a lot, and they have a right pneumonia, all right? And they're not saying right upper lobe pneumonia, but that is what they're implying. That's unusual. That would go with an aspiration. Okay, there have been 2 episodes of wheezing in the past, one at 4 months of age and a second at 11 months, both of which responded to bronchodilators. The infant was born at 36 weeks gestation, delivered via normal spontaneous vaginal delivery due to premature labor. All right, now, the question is, why is a 4-month-old wheezing? Could we diagnose that as asthma? Some physicians would, but that's not what we would do because we know that all that wheezes is an asthma. So this should raise a red flag to you that you have a 4-month-old who's wheezing, because we usually don't make the diagnosis of asthma until about 2 years. So what wheezes? Who wheezes? Reactive airway disease could wheeze. Gastroesophageal reflux could cause wheezing. All right? Pneumonia can cause wheezing. Anatomical abnormalities can cause wheezing. Cystic fibrosis can cause wheezing. Congestive heart disease can cause wheezing. If you're thinking about all those things that cause wheezing, the one thing that's the fine thread throughout that's bringing it together is GE reflux. All right? So you had the aspiration, you've had the history of spit up, you've had the formula and the cereal. So all of this is pointing to GE reflux. She spent 5 days in the NICU where a full sepsis workup was negative. The baby was breastfed initially. She had all of her neurological or neurodevelopmental milestones appropriate for age. And really, if you looked at her growth, you would find that in the first 8 months, she was at the 25th percentile. But over the last 7 months, the patient has dropped to the 15th to 20th percentile. All right? Her immunizations are up to date, and they don't have any exposure to cigarette smoke. We have 2 siblings that are both in good health. There's no family history of perinatal asphyxia, skin rashes, allergies, metabolic problems. They put the atopic dermatitis in there to help you assess if there's a family history of asthma. All right? There are currently no medications that are being used. The infant has no history of diarrhea, no recent trauma. She appears in no distress with good skin turgor. She smiles and is appropriate for age. We look at the physical exam, and it shows that the patient is, with the HENT exam, within normal limits, as is her neck. However, if we could only do one part of the physical exam, we'd want to make sure that we looked at the lungs. So you're going to look to see what is that lung exam. First of all, the baby is breathing with good effort. The next thing that you note, though, on your own auscultation is that the patient has a slight wheeze. However, you're not hearing any rales, and you're not hearing any rhonchi. You listen to the heart. There's no evidence of murmur, and nothing to suggest to you that the patient is wheezing because the patient has congestive heart disease. The abdomen appears to be normal. The extremities show no cyanosis, no clubbing, no edema. You have good pulses bilaterally. And the baby is neurologically appropriate for age. So you need to be thinking, what could this be? We've talked about gastroesophageal reflux, but other things that you might want to include or other ways that they could change the scenario to get you to go down a different road of management for a different case is, does the patient have infection? What would that be about? Gastroenteritis because of all of this vomiting. Does the patient have urinary tract infection? Because, again, I'm going to repeat that young children like this present with vomiting and abdominal pain when they have urinary tract infections. They're not capable of telling us that they have dysuria, polyuria, frequency, urgency, hesitancy. All right? What other things? Neurological problems. Does this patient who's vomiting have meningitis or a brain tumor? Does this patient have phenylketonuria? Do they have galactosemia? All of these metabolic problems present with emesis or vomiting. Could this patient have some food intolerance, such as soy protein allergy, or have celiac disease because they're allergic to gluten? Is there an anatomic malformation? We mentioned here pyloric stenosis. Well, this is a 15-month-old, so this patient certainly couldn't have pyloric stenosis. Does the patient have volvulus or a malrotation? Is the patient taking any type of drug that might cause them to vomit? And again, this brings us back to the gastroesophageal reflux. And I think with all the evidence that you have, that should really be your primary working diagnosis, with the idea that as you order your labs, you'll be ruling in and ruling out other things. So what's our initial plan? Well, they're giving us a lot of tests, CBC helping us with infection, electrolytes looking at dehydration, the urinalysis for the urinary tract infection, the chest x-ray looking to see if there's any more evidence of pneumonia or chronic changes. And they do a barium swallow, and they also do a stool for hemocult. Again, looking at your results, if you look, you'll see that the patient is having some anemia. It's microcytic and hypochromic. All right? The patient may be having some kind of microscopic bleed because of this consistent irritation to the esophagus, all right, because of reflux, all right? You might say, well, Dr. Kerner, I thought that anemia that was microcytic and hypochromic went with iron deficiency. And you need to say to yourself, well, yes, that's correct, but it can also go with thalassemia. It can also go with patients who are taking in sources of lead. And it can also go with patients who have chronic disease. All right? Other things that you want to be thinking about, the stool was the occult blood was positive, and that there was minimal barium reflux with no fistula seen and no hiatus hernia. So we have been talking, and we've been making our assessment, and we've been ruling in and ruling out why we think this is gastrointestinal esophageal reflux. And basically, we need to go on to prove even further that we have our definitive diagnosis. And how we're going to do that is to do a pH probe, which was positive for acid reflux. And we also did an upper endoscopy to go in and to actually assess the tissue. And what it showed was evidence of lower esophageal inflammation. So now you, again, are the managers. You need to say, how will I treat this person? And it really depends on whether the patient has a mild or severe reflux and how long the reflux has been going on. All right? This patient's reflux obviously has been going on pretty much since birth. So it's been going on quite a while. So the first thing you want to do is start with small, frequent feeds and positioning. What does that mean? That means that so that when you put the baby down after a feed, that you don't lie them exactly prone. That you might put some bricks or some elevation to the head of the bed so that they're on a slope, and that it'll be less easy for the patient to have the reflux, all right? Other things that you can use antacids, all right? You can use H2 blockers to help. Other medications that have been used, one is cisapride. The problem with cisapride is that it can have a effect on the QTC interval. So when you're using cisapride, you would have to monitor these patients with EKGs. All right? Other things that you would only use in the severe case would be proton pump inhibitor, and this is really a hydrogen pump inhibitor, and the medicine is called omeprazole. And basically, the problem using this is that it doesn't come in liquid. So it would be a last alternative for a child. And then lastly, if you had very, very severe esophageal reflux, which you couldn't control with all of the above, your last step would be surgery, where they would perform a fundoplication. And the fundoplication is effective in nearly 90% to control reflux. And so it has a good outcome, but it would be the most drastic of the therapies. Therefore, remember that when you're taking the exam, when you're working with patients, the idea is first do no harm, and you want to do the least invasive. And so this really brings us to our case review and thinking about, again, the buzzwords. We've talked about the GE reflux. Remember that if somebody had infection, that fever may be present, diarrhea, It's usually an acute problem. They wouldn't have this infection for 15 months. Neurologic, if the patient had a neurologic problem that was keeping them would most likely keep them from developing normal milestones. So if neurologically they were being affected as far as the GE reflux, they would most likely also have been affected in their milestones. Of course, you could have things like meningitis and tumors, but then you would have associated physical symptoms and more history that would point you in that direction. Remember that metabolic, you usually have a better chance of catching metabolic earlier, right after birth. And so 15 months out would be kind of late to catch a metabolic problem such as phenylketonuria or galactosemia. And also these patients would have abnormal development. As far as food intolerance and celiac disease, remember that that would be associated with introduction of foods, and it would resolve with elimination of food. So if you had somebody that had vomiting and wasting because of celiac disease, if you took the gluten out of their diet, like the rye bread and other foods that had the gluten, that their problem would be reversed and there would be no problem. And then, again, any anatomic problem would usually present at a younger age, and there would be more of an acute presentation. And that'll bring us to our next case of fever and irritability. Thank you.